Hi, good morning. Today I'm going to talk about the commonest thing which we face in pediatric NICU mostly. That one of the commonest complication we come across. It's persistent pulmonary hypertension of newborns. Basically, it is pulmonary hypertension of newborn is a syndrome characterized by sustained elevation of pulmonary vascular resistance and is often associated with normal or low systemic vascular resistance. It is also known as persistent fetal circulation, and it is because due to failure of pulmonary vascular resistance to be fall at birth. There will be a transition from fetal circulation to extrauterine circulation is not complete. That leads to persistent pulmonary hypertension. There will be right to left shunting occurs through PDI, patent ductus arteriosus, and foramen ovale. Epidemiology. It is commonly seen in term or late term babies. The overall incidence is 1.8 per 1,000 live birth. And in post term or in term baby, it is 1.6 per 1,000 live birth. Higher in the baby in late preterm, it is 5.4 per 1,000 live birth. Mortality is been ranging up to 10 in most of the studies. It says that from 7.6 to 10.7%, depend upon the severity of conditions, and it's more common in boys than girls. It's typically seen in term or post-term infants. Mostly gestational age will be 37 to 41 weeks within first 12 to 24 hours. Mostly at birth, we can notice that baby's cyanosis. 10% of them are idiopathic, secondary to certain neonatal pulmonary disease, which leads to delay relaxation of pulmonary vascular rate. It has been classified as primary and secondary. In primary, it's idiopathic due to hypoxemia developed in baby with normal lungs. And in examination, there will be breath sounds will be normal and X-ray will be usually normal. Possible causes of primary pulmonary hypertension will be chronic uterine hypoxia, asphyxia, maternal ingestion of prostaglandin, hypoglycemia, hypothermia, or maternal hypertension. Those mothers who took aspirin near term can cause repeat intrauterine closure of the ductus with redirection of blood into pulmonary vasculature, which can have a idiopathic kind of pulmonary hypertension. Secondary hypertension, pulmonary hypertension can be due to lung diseases. Mostly in common practice, we see because of mucinum aspiration. Second common cause is diaphragmatic hernia or sepsis due to group B strep, pneumonia, or respiratory distress, sepsis, and hypoplasia of lungs. This common presentation, what can be the perinatal and neonatal causes of increased pulmonary vascular resistance, which can lead to persistent pulmonary hypertension. At birth, when the baby takes first breath, there will be decrease in pulmonary vascular resistance, and there will be increased pulmonary blood flow, and there will be increased partial pressure of oxygen. Circulatory pressure will change to after the clamping of cord. There will be a systemic vascular resistance will increase then, and pulmonary vascular resistance will drop, which will lead to lungs to take over the gas exchange. If the pulmonary vascular resistance remains higher and the blood continue to be shunted, then pulmonary hypertension can develop. Signs of pulmonary hypertension. Usually, these babies will have Apgar 1 or 5, up to below 5 in first 1 and 5 minutes. You will see the baby with cyanosis at birth and will worse in first 12 to 24 hours of age. There will be later development will be the baby gradually the cyanosis progress. There will be distress, tachypnea, retraction. Sometimes you can see systolic murmur, and there will be in blood gases will show mixed acidosis. There will be hypoxemia or hypercapnia. X-ray will show mostly mild to moderate cardiomegaly, and there will be decreased pulmonary vasculature. In this kind of cases, usually we do basic investigation initially. Any baby with we think of tachypnea and all, we do septic workup. We do X-ray chest, we do blood gases, arterial blood gases, pre and post ductal. There will be CBC, there will be CRP, blood culture. We try to monitor blood sugars to avoid hypoglycemia, hypocalcemia, and we try to measure electrolytes. Echocardiography is the gold standard to diagnose increased pulmonary hypertension. It is to exclude the congenital heart diseases, especially transposition of greater arteries and total anomaly of pulmonary venous return. In presence of significant parenchymal lung disease, cardiac assessment is less urgent, especially when we do hypoxemia test. Echocardiography is useful to assess the myocardial function, which is often severely affected, and the assessment of severity of persistent pulmonary hypertension. And it will give us the response of the treatment. There will be tracheostomy regurgitation, which allows indirect measurement of right ventricular pressure and therefore the severity of the disease. To see the ductal shunting, there will be shunting through the foramen oval. Hyperoxemic test may play a role of diagnosis, especially if there is less resources of having 2D echo is not available. Uh, However, it will in severe persistent pulmonary hypertension, it will show the same results like congenital heart disease. In past, they used to do cardiac catheterization, but nowadays it has been not done. It is painful, it is traumatic to the baby, and mostly it has not been done nowadays. What will be the goal of treatment for this kind of babies? To the maintain adequate oxygenation. Babies are extremely sensitive. With less touch, baby get desaturated. So handling them less handling, and which will reduce the partial pressure of oxygen. Crying will decrease PO2, and we'll try to coordinate as much as possible. There will be management of IV fluids to maintain electrolyte level, especially calcium. There will be adequate circulatory blood volume to maintain the right ventricular filling and cardiac output, and to give a proper thermal environment to minimize the oxygen consumption. Medication, uh, there are less kind of medications we use, especially in this kind of thing. Inotropic support to maintain perfusion, dopamine, or Miliron, if is frequently helpful in maintaining the adequate cardiac output and systemic blood pressure, and while avoiding excessive volume administration, especially IV fluids and all. Although dopamine is frequently used as a first-line agent, other agents such as dopamine and Miliron are helpful when myocardial contractility is poor. Some of the Cochrane review shows that phosphodiesterase inhibitors like sildenafil are potentially option for persistent pulmonary hypertension, especially if we have less resources and in a level 2 or level 3 kind of setup. Inhale prostacyclin, another option, potentially intervene in the patient who failed to inhale nitric oxide therapy. Surfactant therapy we use, especially if there is a lung, if you think of there is RDS, to improve the alveolar recruitment in the infant with poor pulmonary condition, especially sepsis, pneumonia, meconium aspiration helps, in which surfactant therapy may be impaired. Surfactant functions may be impaired. Mechanical ventilations may be used in persistent pulmonary hypertension, which wanted to use low peak inspiratory pressure to monitor partial pressure of oxygen or partial pressure of carbon dioxide with transcutaneous monitoring. Previously, hyperventilation was kind of an option they used to use to reduce the pulmonary hypertension. It used to be with alkaline infusion, but nowadays it has been considered outdated because it can cause sensorineural deafness and respiratory alkalosis. Babies in hyperventilation, the babies often become agitated when they are being hyperventilated. So mostly sedation they are used at that time. Fentanyl or combination with benzodiazepine they used to sedate the baby. Sometimes we required muscle relaxant, pancuronium or morphine. But nowadays we are not using that much. Only fentanyl we are using, and sometimes morphine. High frequency ventilation is one of the good option to reduce, especially in uh, NICU, to reduce persistent pulmonary hypertension, which will reduce the risk of barotrauma. There will be effective alveolar ventilation. There will be recruitment of new alveoli, and with nitric oxide, it is more effective. High frequency is more useful in secondary kind of hypertension, persistent hypertension, especially with the lung disease, especially mucinum aspiration and RDS and sepsis. This is nitric oxide. Inhaled nitric oxide is the only option been approved by FDA, which is being used as a pulmonary selective pulmonary vasodilators that may decrease the use of invasive therapies such as ECMO. Uh, Potential pulmonary vasodilator. It is one of the most potential vasodilator, pulmonary vasodilator. It will decrease pulmonary pressure, artery pressure, and it will increase PO2. It doesn't cause systemic hypertension. Nitric oxide are more effective in persistent pulmonary hypertension in babies without lung disease. And babies must be weaned slowly off from inhaled nitric oxide or may have rebound hypertension. Some of the studies has been shown that sulfurylin IV or oral with inhaled nitric oxide, some of them still under review, that it help in reducing the persistent pulmonary hypertension, but still it has been under studies. ECMO is the last option for babies who are having still having persistent pulmonary hypertension. It is an extracorporeal membrane oxygenation. It's a form of cardiorespiratory support that allows lungs to rest and also cause cardiopulmonary life support. ECMO has increased the survival rate significantly, especially if there has been non-responding to inhaled nitric oxide or oral therapy or medication therapy. Should be the last resort for everything else has been everything has been failed. The requirement to recruit the baby into ECMO kind of therapy should be baby should be more than 33 weeks gestation age. There will be potential reversible lung diseases. There should not be any bleeding disorders. There should not be intraventricular hemorrhage. Outcome of this persistent pulmonary hypertension, because there are very less resorts. So the mortality rate is 20 to 50% if it's been not treated well. Okay. And there will be, it has been decreased, mortality has been decreased because of high frequency and inhaled nitric oxide. And in ECMO also, it has been decreased in ECMO also. Babies which has been treated previously with hyperventilation therapy and alkaline therapy, they have sensorineural hearing losses. I'd like to talk about one of the cases which we had previously in our hospital with persistent pulmonary hypertension. This was a baby who has been born at 38 weeks of gestation, born by emergency LSES to 36 years old Bahraini mother with gravida 5 and para 6. Mother was hypertension and GDM on diet, on insulin, and was having polyhydramnios at that time. Baby was having Apgar 5 and 8 at 1 and 5 minutes respectively. The birth weight was 3.7 kg, and once the baby was settled, we shifted the baby to an ICU, nursery care. We noticed that at half hour of age, the baby was tachypneic and cyanosis. We noticed that saturation was dropping to 82 to 85% with maximum 3 liter of oxygen with nasal prompt. The tachypnea was more than 60 per minute. As usual, we do septic workup. We started on antibiotic. X-ray was done. ABG was done to see any hypoxia. We had asked Dr. Zakaria to do urgent echo, and we had corrected. There was a problem. Hypoglycemia was there, which was corrected by injection glucagon, and then we had maintained the sugar by IV fluids. There was hypocalcemia, which was corrected. On second or third day, there was neonatal jaundice, which was corrected by phototherapy. This was the X-ray when baby was born, and when we did, there was air bronchogram was seen, and rest of the lung was clear. Actually, there was no pleural effusion. Echo was showing that there was moderate TR and mild MR. There was ASD of 3.8 millimeter. There was mild dilated right ventricle, and right ventricular pressure was almost 68, and there was PDA bidirectional. So baby was kept with oxygen with nasal prong. We started antibiotics. We kept baby on NPO till the tachypnea settled, and IV fluids for maintaining blood sugars. As per Dr. Zakaria's advice, we had started on sildenafil 0.5 milligram per kg per dose QID, and after 3 days, we showed that the baby was started settling. Pulmonary pressure was reduced to 40, and gradually oxygen was weaned off. And baby was started on demand feed. Baby was discharged on stable condition on day 7 and being followed in pediatric clinic as well as cardiology clinic. Sildenafil was weaned off in 6 weeks for this baby. Otherwise, baby was development is fine, everything is fine. Thank you.